are experienced with precision home visiting and have used it in their work and thought a lot about it. So we're very honored to have you all here with us. In this plenary, our speakers will review accomplishments of the past 18 months and invite the audience members to engage and to think about how to use this in the work ahead. We're going to explain a little bit about what it is. What is precision home visiting? Why it is important? And share some examples of how stakeholders, much like you, in programs, communities, and state systems across the country are working together toward a common goal. So without further ado, I'd like to introduce the panel members, and then I'll turn it over to you, Anne. Okay. So our panelists include Anne Duggan, who is a professor at Johns Hopkins Bloomberg School of Public Health, and Anne is also the director of HARC. So if you attended any of the HARC meetings, I'm sure you're well acquainted with Anne. We also have Brenda Jones-Harden, a professor in the Department of Human Development and Quantitative Methodology at the University of Maryland, College Park. Now that's a title, Brenda. And we have Allison Kemner, the Vice President of Research and Quality at PAT National Office. We also have Dr. Kathy Pillow-Price, an Associate Director and Fiscal TA Specialist with HV Impact. So I welcome you to give them your full attention, and I will now turn it over to Anne.
Great, thank you. We're delighted to have this opportunity to talk with all of you. We have 3 objectives for this plenary. The first is to introduce HARC to those of you who are not yet familiar with it. The second is to introduce you to an exciting initiative called Innovation Toward Precision Home Visiting. And the third is to inspire you to be a part of this initiative. We're going to start off with a couple polls, so if you can take out your phones. Here's the first. We want to kind of get a sense of who's in the room and the stakeholder group to which you belong. So we'll give you a minute or so. Okay, can we see results? Okay, so about half the folks in the room classify themselves or self-identify as providers. About 14% national model leaders, 10% researchers, 1 in 7 state-level folks, 5% advocates. Whoa, and it's changing. Oh, more people. So apparently the providers, they vote earlier than other people, right? Okay, yeah. Very good. The point is we've got nearly every group represented, and we have very large representation by providers, researchers, and state-level folks, which happen to be the 3 groups that we have represented here by my colleagues who'll be speaking later in this panel. Let's go to the next poll. How do you see innovation toward precision home visiting and your role in it? Would you say, no idea, I have never heard of this before? Or, I've thought a bit about this, but I really don't see how there would be a role for me. I've been looking into this to learn more about the role I could play. I've actually taken some steps to move in this direction in my role in home visiting, or I'm in, totally. This is a new lens I use in my role in home visiting. Take a minute or two. Actually, let's see the results. They'll change. Okay. So far, about a third of folks, I have no idea what this is. Maybe 2 out of 5 have been looking into it. So we have quite a mix, and we have kind of a long way to go to reach our goals of acquainting you with the initiative and inspiring you to be a part of it. So let me go on. We can go to the slides. Okay, to give you some context, let's start off looking at what exactly is HARC, what is its role, how does it get funding, and who belongs to HARC. So Home Visiting Applied Research Collaborative, HARC. Applied research, not basic research, applied research. That means research that people should be able to use right away. And collaborative, once again, because we are all in this together, and we need all of us working on research to advance our field. HARC is a national research and development platform to advance home visiting, to advance our field. Those of you who are familiar with McVie know that the legislation that authorized it called not only for funds to be spent for the scale-up of evidence-based home visiting, but also the development of a rigorous program of research, continuous quality improvement, and evaluation. And HARC is one of the 4 arms of that program, along with MyHope, State Evaluations, and HV Coin. We get our core funding from HRSA. We get additional grants from national foundations and other public funders. And we leverage the support we have with other aspects of McVie, other aspects of state operations, and so on, as you'll see when my colleagues present later. You see the members of our leadership team. My guess is you recognize many of them. Kay O'Neill is our coordinator. We have liaisons with HRSA and ACF, and we have a National Advisory Council whose members, once again, are selected to represent each of the stakeholder groups that are critical to bring into this new initiative. So who are HARC's members? Membership is voluntary. 15 of the evidence-based models have signed on to be members. There are 240 researchers who have signed on from around the country. Hundreds of individual local implementing agencies, and hundreds more who have joined either as part of a network of home visiting programs at a regional level or a state level. Now that I've introduced you to HARC, let me spend a moment having us consider where we are in this field of home visiting. How did we get to where we are now? Well, we have focused on models. We went from a good idea for a model to research to develop evidence to support the model, and then finally sufficiently rigorous research to have that model designated as evidence-based. We're confident that this model can improve outcomes. We assess that evidence through HomeV, and then through McVie and other efforts, we are now investing in scale-up and in infrastructure to make certain that home visiting can reach its potential as part of the early childhood system of care. Now, our field is where we want it to be in many ways. We're on the ascendancy in terms of service availability. We learned in this morning's plenary, 0.3% families at risk, but we're going in the right direction. We also know from the MyHope implementation report and the impact report that were released in November and just earlier this month, that the programs funded by McVie are in fact reaching the families that we want to reach, those high priority families. This slide just gives a couple examples of statistics characterizing those families. And then finally, we also know from the MyHope implementation report that our local programs provide many supports to home visitors, individually and through their affiliation with evidence-based models. So that's all good. But we are not yet where we want to be in at least 3 important ways. Let's look at the first. Family engagement is challenging. This slide shows that by 12 months after enrollment, half the families in programs that we studied 25 years ago in Hawaii, Healthy Start program, which was the prototype for healthy families, by 12 months, half the families had left the program. Here's what we found in New Jersey when we looked at 65 local programs using PAT, HFA, or NFP. And here are the results for MyHope the past few years. It's a seemingly intractable problem, and one that I think compels us to figure out different ways to do better. And here's some guidance. One of the things we learned in a research study in New Jersey is that families stay longer if the mother feels that she and her home visitor agree on goals, and if the mother is satisfied with the home visiting program's efforts to address her reasons for enrolling. This next slide is very complicated. I've been practicing how to walk us through it. It's also a very, very important slide. For those of you who are not researchers, you might not be familiar with the notion of effect size. Effect size is the difference in outcomes between, in our case, home-visited families and families in control groups. The bigger the difference, the bigger the effect size. And by translating things to effect sizes, you can go from apples and oranges, different outcomes, to apples and apples. Conventionally, 0.2 is considered a small effect size, 0.5 is moderate, 0.8 is large. You don't need to know those numbers, you just need to know small, moderate, and large. On this graph, above the line would be benefits, and below the line would be adverse effects. If we take 4 of the confirmatory outcomes of MyHope, and we look at the studies that were done before MyHope, for the models that were studied in MyHope, these are the effect sizes for those individual studies. And I picked a range of outcomes, right? So family economic self-sufficiency, let's look at parental education or training, for parenting, parental supportiveness, or the quality of the home environment for learning, delayed repeat pregnancy. It's a life course event, right? What do we see? That overall, effects have been small. They've been very small, on average, across all studies. They've been small for most studies, and sometimes they're negative. So yes, our models are evidence-based, but we have a long way to go. I'm going to put in a little plug for the roundtable later today where I think Chuck Michalopoulos and Ginger Knox and others will be able to talk more about the MyHope impact study reports on outcomes such as these. Now, the problem is, though, that when we focus on overall effects, we risk failing to see what's really happening. There might be some important things going on below the surface, and I'm going to show you an example. Consider this overall home visiting effect in reducing poor maternal mental health. Now, this goes back to the study we did in Hawaii a long time ago. And overall, at follow-up, 37% of control moms versus 31% of home-visited moms had poor mental health at follow-up. Right direction, not a huge difference. But look what happens when we separate all the mothers who were targeted and enrolled into 4 groups defined by whether the mother was secure in relationships or whether she was anxious about relationships, avoidant of relationships, or both anxious and avoidant. The secure mothers look best, and they even look the best. They didn't look so bad, even in the control group. The avoidant mothers didn't look any different, experimental and control. And the anxious, or the moms who were both, highest prevalence of poor mental health at follow-up. Home visiting was highly effective for those who were anxious, but if they were anxious and avoidant, no dent. Where do we need to go from here, given those 3 issues I raised? Difficult to engage families, very small overall effects, and differences in effects across family subgroups. Where we need to go is toward precision. And we need to use some methods very similar to what we've been using for whole models. But instead of focusing on whole models, we need to focus on the ingredients of those models, the specific actions that we want home visitors to take. Just as we did with home visiting models, we need to build evidence of which ingredients are in fact active. They are responsible for making impacts in parenting behavior and in family functioning. We can do this work more efficiently if we focus on near-term outcomes, and we are very lucky to be in a time when there are new study designs that are based in randomized trials, but that allow us to learn more quickly what works best for which families under what conditions. So, how can we build the evidence? To recap, let's start with our approach to date. We focus on a home visiting model as a whole. We look at its impact on intended mid to long-term outcomes. And at the end, we analyze all the data we've collected to see which family characteristics moderated made the impact go up or down? Here's how we can do it going forward. Instead of looking at home visiting model, we look at home visiting ingredient. Instead of focusing on intended mid to long-term outcomes, we focus on near-term outcomes. And instead of waiting till the end to analyze the data, separate our sample into various groups, from the very start, we use studied design, these new designs I'm talking about, to test whether family characteristics moderate impact on that near-term outcome, and then to modify our ingredient accordingly and retest to broaden and strengthen the impacts that we see. Here's an example. The ingredient, explicit feedback on parent-child interaction. The short-term, the near-term outcome, sensitive, nurturing parent-child interaction. And the possible moderator, a parent's comfort with relationships. When we test this, we're testing what's called action theory. If we were to go farther, we would be testing conceptual theory, but we don't need to test conceptual theory. The reason that we've been trying to promote sensitive, nurturing PCI is because 1 million studies have demonstrated that that is the key to child cognitive development, language development, and social emotional well-being, relational health, as Dave Willis would say. So to try to take what might seem like a complicated concept and make it simple, we've defined 4 hallmarks of the work we all need to do together going forward. 1, we need to focus on active ingredients. We need to specify what we expect visitors to do and how we expect them to do it. We need to test efficiently, use those new designs I talked about. We need to measure explicitly the ingredient, the short-term outcome, and the potential moderator. And we need to work as partners, because we can't do this unless we are all on board. Now, this morning in the plenary about network building, I was one of the people who was fortunate enough to be in that meeting in November up in Wisconsin that kind of gave birth to the national network. And I heard that phrase, if you want to go fast, go alone. If you want to go far, go together. We've decided we want to go far, but we want to get there a little faster than we would. That's why we're advocating these designs. So I'm now going to turn this over to Brenda Jones-Harden, who'll give us the perspective of researchers and practitioners, because like a lot of us, she wears 2 hats. Brenda?
Thanks, Anne.
Okay.
So couldn't hear before, I'm going to use this, okay? Is that better? Yeah, okay. So I want to thank Anne for inviting me here and for letting me learn from her. Many of you who know me know that I kind of go between being a practitioner and a researcher all the time. Not a good idea for most of you, I'll just tell you. Hasn't worked always good for me, but it's all I can be. It's all I can be. So what I'm going to do is really try to give you some perspectives on both of those frames, thinking about this idea of precision home visiting. And what I'm going to look at is this parent-child interaction that Anne talked about. And just to tell you all a little story about myself, I started out as a home visitor in 1978 in, ironically, a homeless shelter in the Baruch Projects in the Lower East Side of New York City. And I was a loosey-goosey home visitor, really loosey-goosey. And I've tried to get better over the years and got really excited about some of the stuff that's coming out in the literature, and I'll tell you a little bit about what we've done with that. But I'm going to talk about 3 of the hallmarks that Anne mentioned. 1, this active ingredient idea, and it's going to really sort of be about the feedback, video and live feedback idea. I won't talk about the test efficiently because I'm really way behind. I'm in that first slide that Anne showed you where I'm doing subgroup analyses post hoc, and I'm trying to learn from her about how to do it. So I'm not going to talk about that because I'm not there yet. I'll talk a little bit about how we've measured things and then talk about this partnership idea. So this is sort of a practice slide. So I want to tell you in my own work and the work that I've done with students and colleagues, we've always been thinking about how to promote child development. But one of the things that all of you know is that it's hard for us to get there in home visiting, right? We can get those parent and family outcomes. It's hard to get child development. So obviously, one of the near-term outcomes that we think about and work on and we usually get good effects on, thank goodness, is this idea of promoting, nurturing, sensitive parenting, parent-child interaction. So how we think about it from a practice perspective is the loosey-goosey stuff that I did all those years ago, very didactic, very focused on, going through a curriculum and talking to parents about, alternative ways of disciplining and spending a lot of time sitting on a couch with a mother next to us. We don't do that anymore, right? We know from a practice perspective that you gotta be active in the visit. You can't do a whole bunch of talking. You have to make it experiential. You have to be there in a coaching kind of sense. You have to contextualize it and make it part of what the family has as a routine. So we've learned that as practitioners, but fortunately, we have a set of researchers who've also learned it and helped us figure out how to operationalize it. So again, a practice slide where I don't want to think about loosey-goosey home visiting anymore. I want to think about this coaching strategy, and I'm going to read you this quote that I took from a paper by Barnett. Responsive coaching or live feedback during parent-child interactions is an essential skill for interventionists to master. So whenever I consult with home-based programs, and I do a lot of that still because that's where I get my energy and feel like I can go back and be an academic, that's what I tell them. We gotta think differently about what we do with parents. So when you think about this precision home visiting idea, which I learned about from Anne, but have been really thinking about it more and more, didn't have the language for it, but with Anne's help, I'm now getting the language for it. So my question becomes, as a practitioner and as a researcher, how can I promote positive parent-child interaction? When can I do it? Which home visitors can do it, right? Because that's an important question. What strategies do we use to do that? And which families does it work with? Because the truth be told, and if any of you have been on the ground for as many years as I have, you know it doesn't work all the time. So instead of saying, oh, I'm not sure, this family was resistant, and all the stuff that we come up with, can we think more carefully about which families can benefit from what? It's the old Bronfenbrenner question for any of you who are child development people like I am. So we got evidence, right? As Anne mentioned, we've got a ton of evidence about what kinds of parenting gets you what outcomes, right? But we also have evidence from the intervention field about what we can do. So we know we can improve sensitivity and responsiveness. Got a ton of studies about that. We know we can do it with parents who are low risk and who are high risk, even though we might need to use some different kinds of strategies. But look what I have in bold. And this is something that was hard for me. More success with moderate number of sessions. Now, I come out of psychodynamic world, right? So you all, any of you all who were trained as psychodynamic clinicians, you know you don't see a family for less than 12, 24 months. That's just not what you do. So when I had to think about some of these interventions that were brief and they were getting really nice effects, I'll be honest, I was a naysayer. I said, come on, give me a break. 10 sessions, I need 2 years, right? But I had to listen to the data, and the data suggests that we might want to think about some of these brief approaches. And then I started looking a little more carefully at what these approaches were doing, and one of the things was video feedback. And I'm going to give you 3 examples of those in just a minute. But what they got from examples were improved parenting skill in interacting with children, and that's where they got the strongest effects, right, that took me 2 years to get. Increased parental pleasure with the parental role, and enhanced parental well-being. That's what's coming out of this literature. And I'm going to do a shout out to Lori Rogman because I just had to do an assignment for Lori that I was working on till yesterday practically. But one of the things that I learned that was also found in the My Hope evaluation is that when you think about her measure, right, the hovers, right, what you found was that home visitors needed much more training in this notion of promoting parent-child interaction than any other. So think about what those data suggest, that what works is what home visitors need the most support in. So that was just something that was very important for me as I start to think about this work. So again, another practice slide. What have I learned from this work? That you can't do everything. You know, I was trained initially as a social worker, and we believed in comprehensive services, and you did a psychosocial assessment and you tried to meet every need. Well, as it turns out, that's not exactly what seems to work, that you got to really target specific behaviors to get more bang for your buck. And you want to use exemplars of parenting behavior. So if you think about it from a videotape point of view, you can use canned videos, which some of them do, but what I would argue is the most potent ones, and I think the literature suggests that, are actual videos of the parents themselves. And they love it, and they learn so much from it. And I remember when we were first starting to do this, everybody was like, well, they're not going to want you to videotape them and all this kind of stuff. We were dead wrong. And I was one of the ones saying that, by the way. Now, did they want us to show their videos to all the world? No. But they were fine with us videotaping them and sitting and looking at the videotapes with them in the context of the home visiting session. The other thing that I learned about was the import of this whole coaching idea, and I gave you all that, quote in the beginning, that you are on the floor. This is what I would tell my supervisees. You got to be on the floor. When I would go consult, you got to be on the floor. And some people would say, I don't want to be on the floor. I said, well, sit on an ottoman then, do something. But you got to be there with the mother and child as they are engaging together. And I learned this from some recent work I'm doing in Maryland with Healthy Families. You all even have an acronym for this affirmation, the ATP, which I'm an early Head Start person. I had never heard of ATP, accentuating the positive, but now I got it in my brain, right? And that's part of what you do. You affirm what a parent does, and then you scaffold other kinds of behaviors. And then the other thing, and I'll give you all the exemplars in a minute, we learned the importance of having home visitors code their own behaviors, right? And think about that as part of supervision, but also certainly as part of research. And I have to do I have to do shout outs. So I did a shout out to Laura. I'm going to do a shout out to Mary Dozier. I don't know if she's here, but one of the most brilliant things that I think she did with ABC, and that's what we did, was she told us to take the video clips that we did and put them in a montage for families. If you ever want to give a family's incentive, give them a little montage of their best moments. They love it. And our families were asking us for 2 and 3 so they could send them to El Salvador so their families could see them and things like that. They loved them. So just sort of to tell you all that it can work. Okay, so let me give you my examples, and there are many, many examples. I want to make that clear. I'm just giving you 3. These are 3 that I've been talking to folks about, and 2 that I've been talking to folks about, 1 which we did, but know that there are many, many examples of this. So the first one is promoting first relationships, comes out of University of Washington, grounded in attachment theory, 10 visits, that's it. So again, I had to let go of my psychodynamic training as they were kind of helping me to think about this. They give video feedback in 5 of those sessions. They use video of the parents and children interacting themselves. They use a master's level mental health provider. That's what they use, but I'll tell you what we used in just a minute. And what were their outcomes? Caregiver sensitivity and understanding of toddler social emotional needs, child competence, all improved with 10 weekly visits. Okay, example 2, Phil Fisher's FIND, Filming Interactions to Nurture Development. This is sort of based in an attachment theory, but it's also including, the Oregon Social Learning System Center's approach to micro behaviors, which comes out of a social cognitive approach. And they're really focused on serve and return, Jack Shonkoff's term about serve and return. That's all they focus on, nothing else but serve and return. So within that, there are 5 elements. Sharing the child's focus, that's kind of letting the kid lead. Supporting and encouraging, there's your ATP and all that kind of stuff. Naming, right? All of us know about narrating children's behavior, what the parent's doing. Back and forth interaction, and then endings and beginnings. Stopping one interaction, moving to others. That's it. That is it. 6 to 12 sessions. And the interesting thing about this one is that they've created it in a modular way so you could pick it up and dump it down into your model, into your curriculum. That's how they built it. They built it to be modular with the expectation that people might use it as part of a larger model, okay? 6 to 12 sessions, that's it. Video record, parent-child interaction in naturalistic context. They take the clips, and they even have created this sort of center where if you don't want to do the video clips yourself, you send it to the center and they'll do the video clips for you. Now, we did our own video clips, I'll tell you all in just a second, but they're sort of thinking about scaling up and how some of the technology might be too much for some programs. You give explicit, again, positive feedback while showing the clips in the next encounter. Their providers don't have to be mental health clinicians. It can be paraprofessionals, it can be professionals. That's how they built this. And what outcomes do they have? Improved parenting and decreased parenting stress. And by the way, they've done their recent micro trial with fathers. So they have a group of universities across the country where they're looking at using this with dads, which is really something new in the field. So the last example I'm going to tell you about is Mary Dozier's ABC. It's the one that we use. My colleague Lisa Berlin and I just finished this one about a year ago. Mary's focus is attachment theory, as many of you all might know. 10 weekly sessions again. I had to let go of my own approach. Caregiver and child, video feedback. Now this is the important part. In the moment commenting, ITM commenting is what she calls it. And that's her coaching. That's what she uses to work with the parents. And she will tell you, if you ever have heard her present, that she feels like that's her active ingredient. That's her active ingredient, right? In the moment commenting. So, her providers don't have to be mental health clinicians, don't have to be paraprofessionals. She argues education isn't really important. What she argues is they need to be secure in their own relationships so that they're not going to support a mother, accentuate a mother who's not attending to her child's cries, for example, right? So she wants them to feel secure, and she wants them to be able to do this ITM coding. And if you all have ever seen it, it takes a lot of executive functioning, I will tell you that. Because what you're doing is you're observing behaviors and you're looking for the opportunity to give an in-the-moment comment. So I supervised 2 of the staff who was doing this, and I used to talk to them like, you all are prize fighters. You're on your toes trying to respond. I mean, it takes a lot, but it doesn't take a master's degree. In fact, one of our people was a BA person in speech pathology, so she had no clinical background in this area at all, okay? So what outcomes? Improved nurturance, improve following the child's lead, decrease frightening behaviors, and this is important, what they have found is that when the providers do this self-coding of thinking about, am I doing enough? They look at quantity and quality of in-the-moment comments, right? Am I doing enough comments? Am I doing them in a quality way where they relate to the outcome? That when they do that, right, you get better coaching, okay? So the self-coding gets you better practice. So I wanted to make sure you all heard that. So this is the only research slide I'm going to show you. This is from our ABC program, and this relates to that issue about moderated effects, okay? So we got basically replicated Mary's findings in many ways. We got improved sensitivity, we got decreased intrusiveness, overall sensitivity improved. But the part that I wanted to say to you all about this subgroup stuff, we found the most potent effects for the intrusive moms. And when we talked to Mary about it, she said that her argument, because I talked to her about this whole idea of precision home visiting, her argument would be that ABC worked for less sensitive moms. So that would have been something, if we had done the testing well, we would have probably recruited for less sensitive moms and been able to do that kind of explicit testing. So I'm just going to do a quick summary and turn it over. So we've got this growing evidence base about in the moment and video feedback as an active ingredient to promote parent-child interaction, even in our own work. So what does that mean for the field? That we have to think really carefully about what home visitors are doing, right? And I know from my own work, I didn't have a lot of supervisors coming to observe me way back then, and it was some loosey-goosey stuff going on in my visits, okay? So, right, we need to be much more precise and observe what they're doing. And we need to really try to think about how we can transcend models. I think Anne is right. We're not trying to say that any model is inappropriate. Every model works. We've got data on that. We're saying let's take it to the next level and think what we can integrate into the models. And as Phil Fisher's find shows, you can just plop it in, right? How can we incorporate some of these strategies into these more complex models? Do you need to change the models? I don't know. I think it's an empirical question. Phil Fisher and his group would say no, right? And I want to mention to you all that we added ABC to Early Head Start. And one of the things that this was part of the Early Head Start Buffering Toxic Stress Consortium, and one of the things that the Early Head Start folks told us from the beginning, this does not replace Early Head Start. So we did it as a supplement. It did not replace that model stayed the way it was, and we added this ABC as a supplement, and it worked, right? Okay. Do we need to change the implementation system to support visitors? Do we need to think about observation in a different kind of way? But certainly what I hope my reflections have suggested to you all, that we can do this kind of innovative research to learn a lot more about what works best for families and under what conditions. Thank you all.
So I am not as tall as Brenda. Good afternoon. My name is Kathy Price, and I'm going to talk a little bit about the state level perspective. As you know, many decisions about the scale up of home visiting rest with states. Home visiting leaders at the state level have to make decisions about which models to use, in which communities, and which families to target. And they also have to build infrastructure to make sure services are high quality and sustainable while building interagency relationships between staff, partners, models, and LIAs. Part of my role today is to share perspectives from Arkansas, which is where I live and where I served as the director of the Arkansas Home Visiting Network for most of the past 6 years. The network is housed at Arkansas Children's Hospital and works in a public-private partnership between the hospital, the Arkansas Department of Health, and the Arkansas Department of Human Services. And together, they expand, coordinate, and develop the network of home visiting services throughout our state. I know many of you in the audience are here as representatives of states, territories, and organizations. And in the next few slides, I want to explore some ways that Arkansas and 3 other states, Washington, New Jersey, and Maryland, are already moving towards the direction of precision home visiting. I hope to offer examples that will spark your thinking and engage you in conversation around how other states are also engaged in innovation towards precision home visiting, and offer ideas for what your states, territories, and tribal organizations might contribute to this work going forward. First, let's start with my own state of Arkansas. As you can see from this slide, Arkansas has a long history of providing home visiting services that started in the 1980s. And we have been privileged to be awarded a variety of funding from different sources over the years. And with that funding, we have expanded the diversities of models that we support, the total number of families that we serve, and the infrastructure for sustainable services in many ways. But I want to focus on one of the ways that we're leveraging our resources to build capacity towards innovation and precision home visiting. One thing that Arkansas decided to do early on with our McVie funding was to invest in the supplemental training of all of our state's home visitors. And so we designed a training institute that delivers free trainings for the home visiting field, regardless of a program's funding source or their model. We currently offer 39 in-person and 17 online modules and a large annual conference that's devoted only to developing the skills of our home visiting workforce. Dr. Nick Long is the director of that training institute, and our online modules are fantastic, and they are available free of charge to anyone in this room and anyone else that wants to view them. So I would urge you to look at our website, arhomevisiting.org, and you can learn how to enroll in those. So as we discuss precision home visiting in Arkansas, one of the things that we decided was we need to build the capacity of our learners to engage in that work. And what better way than to use our existing training institute as the platform. So I suggested to Nick that we should work with HARC and develop an online training that explains the 4 hallmarks of precision home visiting to those in the home visiting field. It'll be sort of a precision home visiting 101. With the demands of running a state network, sometimes there's a disconnect between the management and the leadership role and how evaluation and specifically precision home visiting can be used to support the decisions we have to make as leaders. So, how many state leaders are in the audience? A lot, yeah. How many of you like money? I do too, and I especially liked it when I was in that state lead role. Well, guys, if we want funders to continue showing us that money, we have to have outcomes to show them. And precision home visiting can help us get there faster. So Nick is working with James Bell Associates, and they are going to pull from their resources and design an online training that will be a part of the Arkansas Training Institute. And since we plan to do it online, that means that all of you in the audience can benefit from it. You can provide information to those in your state so they can become more open about precision home visiting and learn to work in this way. And I think it's really important that we facilitate those discussions in our states and that we teach local programs that they can carry out innovative research as we fulfill our other obligations. So now let's look at Washington State for another example. Laura Alfani is a national home visiting leader and was a founding member of the Ashby Steering Committee. She's also been instrumental in bringing together academic, I agree, she deserves applause. Laura has also been instrumental in bringing together academic researchers and local programs in work that exemplifies the 4 features of innovation towards precision home visiting. When I spoke with Laura, I learned that in Washington State, they are partnering to test small innovations that address active ingredients. This collaboration includes 5 program sites linked to 6 university-based researchers and a working group of program directors, managers, and senior advisors across multiple state agencies. One thing that they partnered on was to design, test, and evaluate strategies that address the challenges caregivers have developing executive functioning skills and what home visitors can do to help with that. When they did this innovative work, they started with a small cohort of researchers and practitioners that partnered together to co-create interventions that they believed would lead to bigger outcomes. They did this by coaching to improve parent-child interactions and parent engagement. And that exciting example of how a state might advance innovation is still ongoing, and I can't wait to follow the results. They are also partnering in Washington to co-create tests with those that are in the field on how to move the dial on home visitor retention rates and how to reduce burnout when home visitors are working with families that have substantial challenges like, for example, substance abuse. In terms of future innovations with precision home visiting, they can see designing some studies around dosage, retention, communication, or furthering their work on feedback and coaching on PCI. They report that central to the success of their innovation approach is testing new ideas and interventions in fast cycle learning. That is, evaluating the work as it progresses, discovering quickly what is working for whom and not working for others, and making rapid adjustments based on those assessments. Now let's look at Maryland and New Jersey and the steps that they are taking towards precision with McVie Innovation Award funding. Both of these states did separate McVie evaluations, and New Jersey found that families enroll in home visiting for many reasons besides to improve parenting, and that mother's satisfaction with efforts to address her reasons for enrolling predicts how long she's going to stay enrolled. Mothers that were less satisfied with program efforts for reasons other than to improve parenting didn't stay as long. Maryland found that home visitors find it difficult to discuss sensitive issues like parental substance use and mental health. Training in motivational interviewing improved their communication skills substantially as measured by observing them talking with mothers in scenarios around substance use, mental health, and other subjects. Together, these states, drawing on what they learned in earlier evaluations, decided to focus on a specific ingredient of home visiting: family goal planning. They wanted to see if they could improve families' achievements of meaningful goals and engagement by communicating about goal plans and by strengthening those skills and reinforcing their use in practice through coaching. This project exemplified the 4 features of innovation towards precision home visiting in a few ways. First, focus. The project is focusing on a specific ingredient of home visiting: family goal planning. Second, partnerships. Within each state, varied stakeholders have come together to refine their goal planning policy and their supportive staff regarding family goal planning. Third, immediate outcomes. The outcome of interest is how well families achieve goals in the short term. And last, efficient test. New Jersey is rigorously testing coaching as a way to strengthen skills and reinforce their use in communicating with families about goal plans. It's using what's called a pragmatic trial. That is an experimental design, but it's carried out in all sites, not just a select few, and with all staff, not just a particular subset. And by carrying out coaching in a way that would be sustainable, if the study finds that coaching does improve how goal planning is used and how well families engage in services. So I hope these examples will get your imagination thinking about how your state, your territory, or tribal organization might promote innovation towards precision home visiting so that next year you can be the example that we're all talking about at next year's summit. We've already learned today that in past home visiting research, overall effects were small, they varied greatly across studies, and were sometimes negative. So, as state leaders, we don't always have great outcome measures to show our funders. And I believe that precision home visiting can help us get those answers faster. The bottom line is, as we build high quality, effective, sustainable state systems, we are being tasked with more and more accountability measures. We need this so that we can show cost benefits and the impact of the dollars that we've been entrusted with. Precision home visiting can help us do just that. And now I'm going to turn it over to Allison, who's going to talk about the model perspective.
Very good. Thanks. And wow, big crowd. No pressure. I am truly honored to be up here with these three brilliant individuals, and thanks, Anne, for inviting me to represent the Model Alliance perspective on precision home visiting. So you heard from this morning's plenary session a little bit about the National Alliance of Home Visiting. Constance talked about some of the common principles that we operate under, the idea that mission, not organization, node, not hub, humility, not brand, trust, not control. Really, I think the big piece is strengthening families and children is at the heart of that work and the work that we try to do. The Alliance, Constance said, couldn't have been made possible without amazing facilitators, Deb Darrow, Miriam Westheimer, and Deb in particular really, I think, has pushed us around this concept of precision home visiting. I want to acknowledge some challenges in home visiting, and some were referenced this morning in the keynote from Lenore Scott from New Jersey, who was talking about some complexities that exist at the state level on the implementation system. The work of home visiting that we do is complex, and from the model's perspective, models have to consider many factors when crafting an effective program. We have to consider families, diverse families, the capabilities and strengths and needs that they present, and their ability to draw on supports and care and provide for their families. We have to consider the communities. Models are implemented in a diverse set of communities. Some communities offer greater support for home visiting than other communities. And some demands actually placed on home visiting programs to fill gaps in services. And finally, with the funding, models face different demands from diverse funding sources. In the case of home visiting, models don't control all aspects of operations. Today, models are implemented within a layered management system. Federal McVie standards and state grantees impact outcomes that are chosen, who will be targeted, and where services might be located within a community. And McVie only funds a portion of models' replication sites. Models have many, many funders that they need to be responsive to. So collectively, these and other issues greatly complicate the implementation process. And then let's not forget the long list of outcomes that's expected of home visiting. So long, it's overwhelming to read it. If we want to say these are all the things we do, we need to be explicit about those outcomes and how we get there. And this is where precision home visiting really offers us an opportunity to look within and across models and implementation systems at specific active ingredients to understand what works for whom and under what context. So, precision home visiting is a new concept, and some of you may still be wrestling with, what does this mean? I'm going to use the stages of change theory, which we often use and think about when we're working with families, but to kind of explain the process that the Model Alliance went through when this new concept was introduced. So pre-contemplation phase. When it was initially introduced at a Models Alliance meeting, there was a lot of questions that came up. Why precision home visiting? How does this fit within home visiting? How can you compare precision public health and precision medicine to home visiting? The work we do with families, how can you compare that to treating a tumor in medicine? A lot of questions. During that pre-contemplation stage, the HARC leadership came and presented to the Models Alliance at the meeting. Jill Filene, I still remember that presentation. And we gave a lot of feedback. What was really helpful was to see that you listened. And in future iterations, you reframed and really put thought into that presentation and the framing. You weren't trying to mimic or replicate precision public health or precision medicine, rather draw from principles and apply it to precision home visiting. And that helped move us to the contemplation phase. So for years, models have been supporting tailoring of services and engaging in continuous quality improvement. Looking for ways to do better has been a way of life of model developers since the beginning. Models have historically been tested as a whole, and the discussion around improvement has centered within models rather than across models. During this contemplation phase, models could see how the concept of precision home visiting could be applied across continuous quality improvement efforts, although there was still a need to further define what is meant by active ingredient. What do we say when we mean what works for whom? How are we defining subgroups? The subgroups question still, I think, needs some discussion, but the definition today explained by Anne of active ingredients, I think, really helps then you get grounded in those definitions. And really, I think Deb and Miriam helped get us to this next phase. We're kind of straddling between preparation and action. So we wouldn't be here if it wasn't for them. Individualizing services is happening in practice already. Home visitors are using data they're collecting from families, making decisions about tailoring those services. So there's some level of precision happening in practice. We are not studying it, and we are not doing it based upon data. That's where the 4 hallmarks of HARC's work comes in. We really need to apply those hallmarks to capture the impact of the individualizing services, being intentional about them. And that will provide us in a more objective review through research of what's working for whom and how we can continue to individualize for different families. So as we move into action, models want to innovate, and we don't have all the answers. And so that's where this idea of this network and bringing everybody together, we know that you might have ideas of precision home visiting and want you to bring those to us to see how we can continue to work together. And I'll share in a moment some of the things we are doing as we move into the action phase. Maintenance. Well, like behavior change, consistency is key. We may relapse, but we'll truly have reached maintenance phase when it becomes a norm of looking at ingredients, looking at home visitors' actions within the visits, what they're doing, and making decisions on what home visitors should do with families based upon evidence. So I do want you to think about, maybe kind of think about where you're at with the stages of change. We did that slide earlier, but consider what more do you need to do? What more information do you need to consider Do you have an idea that you want to share with a colleague? Also, think about in your communities. Think about the model or models you use. And think about the examples Brenda provided. What do you think is the active ingredient in the model in your community? And is there research that supports your theory? So to review the 4 hallmarks of HARC's work and some of the things the Alliance is doing moving forward to support these 4 hallmarks. Active ingredients focus on what visitors do. Models are looking at new ways to explore ingredients. The role of the home visitor and we need to provide better support and training for what that home visitor needs to be doing in those visits. Brenda spoke about parent-child interaction, which is one common element across home visiting models. And although there might be differences in what the models are asking the home visitors to do, that's a common element that we can look closer at. And we need to be more explicit about what we're asking home visitors to do. A future opportunity that we think is very critical, and it's probably the most critical element in home visiting, is the relationship between the home visitor and the family. This includes the idea of respecting the family's perspective. We have an opportunity really to dive into that relationship and understand that further. Understand that different families may respond to different decision-making and communication styles used by home visitors, and that is really a big opportunity for research, and the Model Alliance is interested. Test efficiently in what works for whom. While there are similarities across the home visiting models, there's many, many differences. Enrollment criteria, age of children, length of service, types of service, and outcomes. Some models have existing data systems within them, and we are looking at an opportunity to, can we mine some of that data? This wouldn't necessarily fit within test efficiently, but it could inform future precision home visiting research questions by building off of some of that data that we have and looking at key characteristics, impact engagement, and family performance. Additionally, models are going deeper in how we are defining variability in our populations, moving beyond demographics to consider family characteristics, strengths, and stressors. Strengths are critical when thinking about what works from whom, and they're often left out of the conversation, so we want to make sure that they're considered. Measure explicitly. Precision home visiting does introduce us to new research methods, and a shout out to a session tomorrow, 10:15. Matthew Pose and Lauren Suppley will be doing a session on explicit measurement if you want to learn more. But CQI is one method that can be used in precision home visiting, and I think it needs to be used with the lens of precision home visiting, which is something the models intend to engage in. In addition to considering different research methods, we need to consider what types of measurement, which this gets back to what Brenda was talking about with the observations. We need more observations and audio recording of what's happening in those visits. This will really help us uncover some of the communication strategies, relationship building, and individualizing of services that's happening in that visit. And finally, work as partners. We see the model's role in convening discussion forums and learning opportunities for our state and tribal administrators, local organizations, to engage with research partners, which many of them already do, to design research projects that utilize the type of innovative research strategies that align with precision home visiting. States and home visiting models have been developing learning management systems. At Parents as Teachers, we have developed ours, and we're looking at ways we can support this dialogue around precision home visiting through some of those platforms. Models have national conferences, and states have home visiting conferences, and I encourage you to reach out to the HARC leadership to come present and maybe engage in dialogue with some of the key stakeholders at those conferences. We invited the HARC leadership to present at the Parents as Teachers conference last year, and it was a great conversation in introducing the field to this new concept. And finally, there's a need for all of us to play a part in this work with precision home visiting. If we're actually conducting the research, informing it, being more explicit about what's in our models, to really understand what works from whom, we're in this together. Looking ahead, that's a lot of steps. But we do have this opportunity to go deeper and really, Anne shared, and I think that this is a good frame for it, it's the next evolution in home visiting. We have been doing great work and we should celebrate what we've been doing, but we can do better. So how can we go deeper with understanding what works for whom and key ingredients and having research to support our work with families? Thank you.
You can hear me? One last poll question. While you're putting in responses, I'm going to go to the next couple slides, and then we'll look back to see where we leave you at the end of this plenary. We're hoping that this is just the start of the conversation, and that you're all going to keep the conversation going, that you're going to ask one another within your local program, within your model, what exactly are our active ingredients? And for the ingredients that you think are active, asking, what evidence do we have that this particular ingredient is an active ingredient? Allison mentioned all of the management information system data. How might those data be mined to learn more about what works best for whom? Talk with one another about how might we modify ingredients that are active for some families but not for others. What about the sequencing of ingredients? The fact is we focus on families that are facing multiple adversities. Kids can't wait. Nobody argues that, oh, well, we need to take care of the depression first and we need to take care of the substance use first, and then we'll get around to the parent-child interaction. But if you have a family that's substance using, a family that where the parent has had difficulty dealing with past trauma, do we need to modify services? Do we need to do 2 or 3 different things in tandem? What is the right sequencing? And then how do we know that our visitors can, in fact, use these ingredients as we would like? I'm a huge proponent of observation. I don't see how we can have confidence that we are providing our home visitors with the supports they need to do their jobs the way they want to and the way that families deserve if we don't watch them. To keep the conversation going, we hope you'll visit our website and join HARC. John Korfmacher is leading the development of a community of practice on communication skills. There's some information here for sites that would like to be involved. Allison mentioned we have 2 workshops during the rest of the summit, one of them today, one of them tomorrow, and I'm going to go back to that poll. And can we see the results from the poll? Ooh. I'm thinking that's good. Very good, very good. I do have some questions that people ask, but mostly I use too much jargon. I said PCI and HFA, and I'm sorry. Will there be a copy of slides available? Yes, absolutely. Brenda, right on target, someone said. And I think, oh my, okay. I think, where are we time-wise? We're over. Well, there was only one other question. While precision home visiting focuses on what home visitors do, how have you or can you see how precision home visiting can focus on supervision?
Yes.
And the relationship between supervisors and home visitors? Absolutely, absolutely key. So I have addressed all the questions. Let's keep the conversation going.